Start. For this patient, we have already done lower implants, not full, but almost full. Only 2 premolars and molar are present. They are also not very good. Maybe 1 year back we did. When we did? Below. More than 1 year. Okay. Usually we won't do like this because the patient is having only anterior chewing. Okay, now the patient came for upper. If you see, because of only the anterior chewing the patient is having, all the premolars, canine, there is severe bone loss. Okay, almost gone. So this is the main problem when the patient is having only the anterior chewing. Anterior chewing and unilateral chewing are more common and more worse than periodontal and decay problems. People lost more teeth than decay and gum disease because of this wrong chewing pattern, either anterior chewing pattern or unilateral chewing pattern. Okay, so we must have informed this risk, no? We must have got some consent. I don't know how to check. Now the patient has come for upper. So this is the second premolar. So we have to see how many implants and what is the bone quality between premolar to premolar. Okay. So right side 2 premolars are present. We will start from the second premolar. Okay. Actually, we are planning for screw retained processes. Okay, single piece multi-unit. So we will place one implant in there. This is the second premolar. Okay, just axial, tilting palatally. Okay, you can place here simpler than 4.115 or 3.7515. Okay, if you see, I have placed only the axial. We have not tilted mesially and all. I'm just tilting distally. Okay, if I'm tilting distally, it is into the sinus. Okay, now I am slightly tilting, slightly mesially. The more I am tilting mesially, you can see it is in the good quality. Even you can refer the nasal here. The bone's quality is good. Anyway, we are going to place compression implant, so it will get stability from here by compression and by second cortical bone from the nasal. So it will get a good stability. There is no doubt about that. So second implant we will place in 1-1. Okay, that's the key area. Okay. This is one trick. Instead of adjusting here and there, you can just pull it towards the midline. Okay, so we didn't see the clinical picture and all. We didn't know, just we jumped into the radiographic planning, which we should not do. So how much alveoloplasty we have to do, we don't know. Okay, so tentatively what we will do, we will do alveoloplasty till the apex, almost till the apex. Okay, we will leave little bit of apex of the socket. You have got a good bone here, luckily. Okay, even the nasal floor is around 2000 HU, which is excellent. Either you can use a compressive implant 15. The simpler end is having only till 15, which is a drawback. Or you can use a basal, but you should extend till the nasal. Okay. So if you use a compressive implant, it won't reach the nasal floor. If you want to reach the nasal floor, you can. So I feel you can place a compressive implant because the alveolar bone is good. The bone below the nasal floor is good. Okay. So we'll see the 360 degree how it looks. Okay. So you have to see the canal. Okay. You can see the incisive canal. It is also safer. Okay. Now we are placing another implant in the first premolar. Okay, you can see till the apex there is bone loss, but fortunately beyond the apex of the premolar you have got some good bone, not some little good nice bone. Okay. We are starting another implant from the second premolar, but it shows close to the adjacent implant. Okay, maybe adjacent to the central incisor. So what we'll do, but now it may be adjacent to this implant. It looks okay, no? Why it is showing that? You see the 2 mm is the implant to implant safety distance. Okay. So the thing is, in the software it shows they are close to each other, but in reality it may not be a problem, because here this is almost a parallel implant, but what implant we are going to use is it's a tapered one. So it may not be a big issue. So to avoid this implant close to each other, one technique what we are doing is these two implants, no? So this second premolar implant is palatally tilted. What you can do is the first premolar implant you can tilt towards the labial. You can see immediately it becomes yellow. Okay. So if you go palatally, it is closer, because that implant is also palatal. The previous implant is also palatal, and the one implant is also palatal. So that is why, yeah, you can not mesial, buccal, yes, labially. So this is the canine line, right? Almost the nasomaxillary buttress. So what you can do is, see, if you see it, this is the buttress. This is the buttress. So in this area you have to come close to labial. You should not perforate and come out labial, close to labial. That is why opening flap is good. In this kind of situation, it is better to open the flap till the nasal floor. You have to expose the lower border of the nasal floor also, and you can see the nasomaxillary buttress also. You should see, open the flap and see. So when you are drilling, you will come closer to the labial aspect. So for full mouth, opening the flap only is not enough. You have to open till the nasal floor. Sometimes these kind of tight situations you can open till the nasal floor. You have to expose this little bit of nasomaxillary buttress. Nothing wrong in it. Okay, so totally 3 implants. Okay, we will check the one implant one more time. Even this you can manipulate, no? You can come closer to the labial or go palatal. In this way you can avoid implant close to each other. So right side is okay. Do we need a pterygoid? Okay. You can place a pterygoid or you can avoid a pterygoid. If you are placing single piece, definitely this 3 implant is not enough. Okay. Can you place one more implant here? The 1, 2? No. It will be definitely a tight. Okay. Definitely it will show red, because it is, see here, do not see panoramic image. It is close actually. Okay. So this is the point we are already repeatedly discussing. Panoramic view will cheat us. You may feel, no, I will place one implant here, one implant here, one implant here, one implant here, one implant here. But practically that is not possible. Here at the teeth level the arch form is very wide, but in the nasal level the arch form is short, it's constricted. If you don't understand and if you place multiple implants, the inter-implant the rule is compromised and you get very thin bone between the implants. Either you may luckily escape or the bone loss may happen, implant failure or first stitch loss may happen. Okay, this 3 implant is enough in the anterior area. Can you place implant in this molar area? We don't know, we will check now. Okay, see there is no bone actually. Okay, we will go to the 7. Okay, very thin bone, maybe 5 mm bone is there. You can place a basal 3.610 or something like that. Okay, but not very good bone, very thin bone. Okay, we'll delete. Now so this is the pterygoid area, right? So this is the pterygoid area. The pterygoid doesn't come fully in this CBCT. If you see, the sinus has come, expanded and invaded the entire tuberosity. There is no bone here, right? If there is good bone here, you can easily place on pterygoid implant. But now what you have to do is you have to cross the Atlantic Ocean, the sinus, and go and catch the pterygoid, which becomes the pterygoid becomes challenge, because once you enter the sinus, it becomes a blind procedure. If there is bone, it will guide our drills. Since there is no bone, our drill will be freely floating inside the sinus. Even if you perforate this pterygoid, your implant may find difficult to perforate the pterygoid. So always transsinus pterygoid is much challenging than the regular pterygoid. Okay. Anyhow, it is a good pterygoid. Okay. We'll see the 360 degree. Okay. See, now you are crossing the sinus and you are going into the pterygoid. See the pterygoid 1400. It is good only. So there is one more technique we can use is, even you can use a compressive ear. Even though you are crossing the sinus, nothing will happen. Only few millimeters it will cross the sinus. If you use a compressive, it is easy to catch the osteotomy on the other side. But Simpleton doesn't have 18 mm and all. It is having only 15 mm, which is a big drawback. Okay. But in this situation, I feel is, if you place these 3 implants good, that is more than enough. We can give a cantilever. Okay, you can give one molar cantilever, nothing wrong. So cantilever is accepted if you are giving screw retainer processes. Anyway, we are going to give a titanium bar, milled bar. So over the bar you can give processes with 1 molar cantilever. Okay. Now we plan for the left side, 2-1. Okay. Always place 1-1, 2-1 implant. They are key implants. Okay. That's what I told. It's easy to plan now, placing here. See, the nasopalatal canal is not very big in this patient, which is lucky. Imagine if this nasopalatal canal itself is very big, we have less bone for our implant. Even though it is a 1-1, 2-1 implant, it is actually not in 1-1, 2-1. It is almost between 1-1 and 1-2 or 2-1 and 2-2. Because to avoid nasopalatal canal, we are moving away from the exact 1-1 or 2-1 location distally. Even though it is a 1-1 implant, it is not in 1-1. It is little closer to the 1-2 or 2-2. Okay. Here also the bone is good. Anyhow, we are going to use a compressive implant 15. That is the maximum length available here. If you want to cast the cortical bone, then you have to use a 20 mm or 23 mm BCS. Okay. Here I will see the 360 degree view. Okay. So this is the canal. Just we have to avoid the canal. That's it. Can you see the canal? It is starting from here. It is going here, right? Can you see? It is going right. See here. Okay. So if you see here, it is It is tilted distally. It looks like that is the problem with panoramic image. Okay. If you move more mesially, you will be entering the, you will be becoming close to the nasal septum. Nothing wrong in if you catch the nasal septum. But anyway, we are going to use a 15 mm implant only. So implants touching each other is not a problem, right? So 2 in implant. Okay, can you see? So this is a 2-1 implant. It is not in the 2-1 actually. No? Between 2-1 and 2-2. Clearly always it is like this. See if you can understand this concept now here better. So this is the incisive canal. Okay. If you place implant in 1-2-1, you may interfere, encroach the incisive canal. So you have to drill lateral to the incisive canal, which is definitely between central and lateral. 2 implant. Nice good 2 implants in the anterior, that is, it is must. Now we will place the 1 implant at the second premolar, which is missing. Unfortunately here the bone is less. Okay. See, in the panoramic view I have placed implant in the second premolar. But if you see here, it is partly in the sinus. That means sinus is invaded second premolar area. Okay, compared to the left side, sorry, the right side, left side is sinus is expanded anteriorly. Okay, so this is second premolar, straight axial planning. Only how many mm? 8 mm. Okay, if you tilt slightly palatally, you can increase a little bit, maybe 8 or 10 mm. Okay, 360 degrees. Okay, now if you tilt mesially, see, you can beautifully see the sinuses coming in front till the premolar. Okay, now how we are avoiding the sinus? Tilting. So this is the basic for all the tilting concept, all on 4. That tilt, this tilt. Okay. Okay, now just slightly angulating mesially. Okay. Now we'll see the 360. If you see here, this part is slightly in the sinus. Okay. Slightly distal part of the implant. But that is not a problem, because this implant, software it is parallel implant, but what implant we are going to use is a tapered one. But you can even tilt this slightly anteriorly. Okay, now it will be inside the bone. So buccolingually, you can either tilt palatally or labially. You have got lot of freedom. So that is why it is better to open the flap till here, so that you will get a sense of idea. I am coming palatal or buccal, whatever it is. So actually this implant we are placing close to buccal. Okay. Right? Can you understand? This is the nose, this is the palate, this is the buccal. So your eyes should get accustomed with the CBCT multiple sections views. Otherwise it's difficult to follow. This is must. Now, so we have to park, it is similar to car parking. We have to park our car without hitting the we can actually park from the first premolar. Okay. Okay. See here we placed in 2-1, 2-2. One more in the 2-4 easily tilted. We are trying to place 2-4 tilted, but one more option is you can try from the canine area. Okay, slight mesial tilt. Because if you give a distal tilt, you will hit this implant. If you give too much tilt, mesial tilt, you will hit the 200 implant. So in between you have to go. So that is the carpacking. We are coming to the canine area. Okay, what we can do is we can tilt very close to labia. Okay, what I will do, it shows close. So how to understand this, what you have to do is first you have to remove the mandible. So we will get your idea. Okay. See, no? So it is too much mesially tilted. Which one?
Canine implant.
Canine implant. Right? Okay. You have to modify this. You may feel no, the entire implant is outside the bone. And this is the starting point. Okay. So this implant from the 2-5 area we are tilting towards the buccal. This canine, almost we are going along the apex of the canine. Okay. Right? Even though in panoramic view they are looking very closer to each other, it is not showing red. Why? Because the 2-5 implant is buccally tilted. We are starting palatally and drilling towards the canine, that mesomaxillary area, buccally. But the canine implant we are going almost straight, but towards the palatal aspect. Okay, this implant is coming buccally, this implant is going buccally. That is why even though they are looking closer in the panoramic, that is why you should never believe panoramic view. Just you can take it as a guideline, but okay. See, if we tilt this implant palatally, then it shows close, right? So this is one trick we should know. Tilting buccal and lingually to get a good inter-implant distance. Okay, so the left side is little more challenging than the right side. So what all the challenges we will get on left side is we have to give the exact mesial tilt. If we don't give the tilt, we may enter the sinus. So one more option in this scenario we will try. You can put a short implant in the second molar, second premolar. Okay. Say 10 mm. Okay. Okay, very short implant. Remove this. And we can place a good implant on the second premolar. Straight forward. Okay. So the drawbacks, the C.Murugavel implant is not in very bone. Otherwise, we have to give pterygoid. You will see the sinus area. Sinus area is not good. Okay. Full sinus intersection we have to give to the pterygoid. pterygoid doesn't come fully, right? Even here the sinus is expanded. You can see the sinus is expanded till here. So the pterygoid will be challenging. So we try to place implant in this manner without pterygoid. Okay. So doing single piece in this kind of scenario, it is not a good idea, especially with welding. Because the last pterygoid, when you put BCS, it will be too elastic, too flexible. And if you do welding, no, the inter-implant distance also will be more. Okay. So better to go for titanium. If you are planning for single piece, better to go for a metal framework. You should not do welding. Welding will lead to failure. Okay, and another problem if you do pterygoid in this patient with single piece, the pterygoid angulation will be more around 45 degree. The abutment will come angulated, not straight. So you will have prosthetic challenges, insertion, all difficulties. So one option is either we can go for pterygoid with screw retained. Okay, single piece multi-unit. Or if you are going for cement retained, you have to go for metal frame and metal acrylic or whatever it is. Or single piece multi-unit if you go, you can avoid pterygoid also. You can give cantilever. That is the advantage of single piece multi-unit. You can give cantilever which is not there in single piece cement retained. Okay, because of the difference in biomechanics. Okay, finish.